Thank you so much. And it's really our pleasure to have our kickoff webinar with the help of Global Genes and this alliance with rare diseases. And today's webinar, we're going to discuss Graves' disease and thyroid eye disease from both a physician point of view, but also a patient point of view. We have the immense pleasure of having Christina, who is a former patient of mine, talk about her journey. And we also have Dr. Babak Larian, who is a thyroid surgeon and understands all things endocrinology and thyroid. And so it really is a great pleasure for me to be amongst this group and to really speak. And I'll be speaking a little bit about thyroid eye disease in just a few minutes. What I thought would be easiest to do would be a very brief introduction by both Dr. Larian and Christina, and then maybe let Dr. Larian talk a little bit about Graves' disease for a few minutes as we begin to field some questions, because my topic will dive in more into the eye disease, but I think it would be great for him to set the stage a little bit about what is Graves' disease, how it may differ from Hashimoto's disease, another thyroid autoimmune process, and then we can kind of dive into the eye aspects and field questions as we go. And so with that, I'll let Dr. Larian briefly introduce himself and Christina, and then we'll transition.
Good morning. It's a real pleasure. Thank you, Ray. Thank you for including me in this. I'm really proud to be part of this team, to tell you. My practice is mostly treatment of thyroid disease in terms of surgical approaches to it. Mostly cancer-based treatment, but also treatments related to autoimmune disorders of the thyroid, specifically Graves' disease, and when the need is there for surgical intervention.
Great. And Christina, I really appreciate you joining us the most. I know that this is a tough subject to talk about, but I'd love to, have you give just a brief introduction, because you'll really be the star of the show as we move forward.
So real quick, my name is Christina. I was diagnosed with Graves' disease in 2006 and with thyroid eye disease in 2011. I met Dr. Douglas in 2013, and he did orbital decompression in both of my eyes. And it was the best decision I've ever made, and I am extremely happy with the results. And I'm always happy to help spread the word about this disease and help out in any way I can.
Great. And so my name is Raymond Douglas, and I specialize in thyroid eye disease, and I do a lot of surgery for this disease, but I also really try to take a very holistic approach. And we'll talk a little bit about surgery and medical therapy today, but there will be other webinars and other things on our website really dealing with the problems associated with this disease and how diet and other things can dramatically improve this disease process too. So I don't want you to think that this is all about surgery or all about medication, but this particular webinar is focused a little bit in that direction, but I really do believe that it's awesome to really have a holistic approach in this manner. With that being said, I'd like to start talking about thyroid eye disease. What is it and how to treat it? And I have no financial interest in presenting this webinar, but what is, thyroid eye disease? And in this particular step, I will take a step back before I dive in, and let Dr. Larian talk about Graves' disease and what is Graves' disease, what is the Hashimoto's, what is the autoimmune thyroid, and then I'll dive into thyroid eye disease.
Thank you, Ray. So to start, there are two main types of autoimmune diseases that occur in the thyroid gland. An autoimmune means your immune system attacks an internal organ by mistake, thinking that it's something foreign. As it would attack a bacteria bacteria or a virus. And so when this occurs, the immune system by mistake attacks the gland or affects the gland. And it does so by producing antibodies. In the case of Hashimoto's disease, antibodies are to a thyroid peroxidase, which is a certain chemical compound that exists in the thyroid gland alone. And the antibodies attach to that chemical, and the immune system follows the antibodies, thinking that they're attaching to something foreign, and thereby attacks the thyroid gland. Because these antibodies are specific to a certain chemical in the thyroid gets inflamed, and over time, the functioning of the thyroid becomes impaired, and so the gland works less and less. And generally, over time, patients who have Hashimoto's develop a low functioning thyroid gland, or hypothyroidism. In terms of Graves' disease, the antibodies in Graves' disease are towards what's called a thyroid-stimulating hormone receptor. So just to preface that, the thyroid gland works by producing the thyroid hormone T4, which goes into the body and turns into activated form, which is T3, which is what controls our metabolism and a lot of function in the body. This T4 and T3 circulate in the bloodstream and go to the brain, and in the brain, in the pituitary gland, there is the center where it sees how much of this hormone exists in the body and regulates it. When the pituitary gland or your brain thinks that you have inadequate amounts of hormone in your bloodstream, it produces TSH, which is thyroid-stimulating hormone, which courses through your bloodstream, goes to your thyroid, and stimulates the thyroid to produce more T4. When you have an overabundance of T4 and T3, then the pituitary gland or your brain says we have too much of this hormone, decreases production of TSH, or it decreases thyroid stimulation. So there's a feedback loop. The antibodies that occur in Graves' disease are directed to the receptor, or to the if you imagine a locking key type of thing, the key is thyroid stimulating hormone, and the lock is the receptor. It's where that stimulating hormone settles into a cell and unlocks the cell to produce more thyroid hormones. So the antibody in Graves' disease attaches to that lock and stimulates that lock and unlocks it, and the cells are promoted to produce more thyroid hormone. So in Graves' disease, the thyroid gland is getting stimulated, and the gland is overactive, and it keeps producing more and more hormone, and it creates an abundance of thyroid hormone, and which causes all the problems that you see in terms of side effects from Graves' disease. Not related necessarily to the eye. The eye has another issue and another pathophysiology that Dr. Douglas will discuss, I'm sure. And so this causes the gland to grow and become larger as it's working more and more. It's larger and larger, and it produces more and more hormone. So to diagnose the patient who has hyperthyroidism, you get thyroid labs and you see an abundance of thyroid hormone. That's a question of TSH, because the brain is seeing that there's too much thyroid hormone and it's getting suppressed, and so no more stimulation. But that stimulation is coming from the antibody, right? And so the second part of diagnosis is getting serum levels of the thyroid-stimulating hormone receptor antibody to see if that antibody is existing. And in the case of Graves' disease, you'll see a high presence of this antibody, and that's crucial in making a diagnosis of Graves' disease. Okay? Once the diagnosis is confirmed, then the patient has options in terms of how they choose to treat it. The recommended course of treatment is, of course, taking medication, thyroid suppressive medications. But the three options are thyroid suppressive medications, radioactive iodine, or surgery. We almost always recommend that the patient start with the medication to try to suppress the gland, get everything under control. And in terms of adults, that recommendation is to do 12 to 18 months of that medication to see if you can suppress the gland and suppress the system. And there are times when the patients go into remission after getting 12 to 18 months of the thyroid suppressive medication. And so that's why we try to not go to the more intrusive treatments, the radioactive iodine or surgery, as primary choices. And sometimes patients have bad reactions to the medications, or are allergic to it or so on and so forth, or choose not to take medications, then therefore they have to choose either surgery or radioactive iodine. But the primary choice is medical treatment, obviously optimizing the health of the patients, just like Dr. Douglas was talking about, looking at the patient holistically and trying to take care of them as a whole and optimizing the whole system. And during that period, if you can optimize them and test and put the patient into remission, obviously that's the intended goal, to get the patient into remission and prevent any further complications and so on. If that doesn't work after 12 to 18 months, again, the patient is faced with the same question: do I continue with medication, especially if the medication had worked when they were on it, or do I proceed with radioactive iodine and treatment or surgical treatment? And again, that choice is based on how responsive they were, how they reacted to the medication, if they had a side effect to it or not, or what other complications are arising from Graves' disease. And so that's the basics of how you should approach getting the diagnosis and how you should face treatment options.
Awesome. And I'm sure that many people will have questions regarding, their particular circumstance and what they may do, because I know this question comes up a lot. And so as I started, and now we're going to continue to talk a little bit about the eye disease process and what it is and how to treat it. And what thyroid eye disease is a continuation of this autoimmune process. So the immune system now, instead of just attacking the thyroid, begins to attack the tissues around the eyes. And those tissues are either the fat or they're the muscles that move the eyes. And they either cause swelling of the fat or swelling of the muscles, or both. And the three components of this disease, just as we can see here, are both the thyroid, the eyes, and even the skin. Probably the central common feature of all of these are the fibroblasts that are in this disease and that are being attacked in each of these locations by a certain receptor. But what happens is that this results in a very heterogeneous eye disease, where some patients have just bulging fat, some have muscle involvement, but some have the fat around their cheeks and skin involved also. And this can result in double vision, blurry vision, painful vision, but a very heterogeneous disease. And you can see even on a CT scan, when we look inside, so to speak, or you can see on this scan, and I know there probably aren't experts in this, but you can see that the muscles, these things that are holding the eyeballs to the back of the orbit, so to speak, the long, thin muscles are normally very strap-like and thin, and here they're very much enlarged, and that's what causes the double vision to occur. And during this disease, we've often wanted to figure out how to stop the disease from progressing. And unfortunately, we just have not been able to up until this point in time. There's the active phase of the disease where there's this active inflammation going on, and then the disease kind of calms down, kind of the same way you have an infection. Maybe you get infected with a virus and you have this active, very virulent inflammatory phase, and then it calms down. You always have an immunity to that virus, if you would see it again, but you no longer have progression of the disease. Now, that doesn't mean that in this case that the thyroid eye disease goes away, or the bulging goes away, or the double vision goes away. It just means that it doesn't change. And that's really important to know, because when it doesn't change, that's kind of the sign of this stable phase. And that's when we would normally think about surgery and other improvements, in that way. So in general, thyroid eye disease is an autoimmune, meaning your own immune system attacks the tissue in your body, inflammatory disease, and it has lots of scar tissue or fibrosis. And what's underestimated many times is the permanent facial disfigurement. Not only do the eyes bulge, but sometimes the cheeks bulge, the eyebrows, your whole face can change. And that's one of the things that we strive very much to return for people, is their return of their facial appearance, of who they are. And there's really no treatment thus far that prevents this disfigurement. And I will talk about a novel therapy in a little bit that really is giving us hope, but up until now, there really has not been. The standard of care has been to watch and wait. And so this led to the idea many years ago in our lab and laboratory of Terry Smith, who's a close friend and collaborator. What about thyroid eye disease specific therapy? So instead of just using steroids or other things to dampen the immune system, could you actually create a therapy just for thyroid eye disease? Well, to know that, you'd want to get to the underlying molecular mechanism, the root of the problem, so to speak. What is the immune system attacking, and how can we alter that? Well, that led to the discovery and a lot of research about the IGF-1 receptor. And we don't need to go into that here, but that appears to be one of the two receptors that this immune system attacks. The TSH receptor that causes all the endocrine hyperthyroid problems, but then also the IGF-1 receptor that sits very close and is kind of connected to it, that probably causes many of the eye issues. And then this led to looking at a drug which actually blocks this receptor. It just kind of turns it into a stealth receptor where the immune system flies over it and doesn't attack it. And that led to a trial looking at a drug called teprotumumab, kind of hard to say, but easier just to say Tepro, to see whether this drug could actually make a difference for people. And the idea here is that you use teprotumumab or Tepro very early in the disease process to try to eliminate or really downregulate the immune system or the appearance of this receptor so that the proptosis and the double vision either don't occur or are reversed. So a pretty lofty goal. Well, this was published about a year and a half ago in the New England Journal of Medicine. And it appeared to really dramatically improve thyroid eye disease. And then the phase 3 has more recently been released. It seems to confirm this very, robust response due to this drug. This was a trial where some patients, half the patients received the therapy and half the patients received a placebo, and then they were followed. And it's an IV therapy that's given every 3 weeks. And the study was that you had to have early disease. So unfortunately, a lot of people contact me and say, well, if you've had the disease for 10 years, can you still get the treatment? Well, we don't know whether it would work in that point in time, but what we wanted to test during the active phase or during this early phase of the disease, say less than 9 months since your diagnosis or the symptoms started to occur, could it affect the disease? And that's how the trial was designed. So less than 9 months since the diagnosis of thyroid eye disease, moderate to severe disease, and an inflammatory disease. And we really wanted to test whether this drug would medically replace surgery, meaning can it reduce the eye bulging, the double vision, improve the quality of life that's associated in such a detriment to this disease. Well, it turns out that the clinical activity score, which is just a sign of the inflammation, how much redness and swelling there is, dramatically improved even very early, just with a couple doses. So patients were really seeing a pretty big difference quickly with this disease, with the drug. And surprisingly, for the first time ever, never seen with steroids or any other drug, we were able to see a reduction in the eye bulging even after 2 doses. And this continued over the 24-week period. This is just a demonstration of the individual patients from that phase 2 study. On the right side in the blue, just showing that they're mostly below that horizontal line at 0, meaning that almost all patients improved, at least somewhat. And this was really encouraging for us, obviously, because it could represent the first time that there's an actual drug that really targets thyroid eye disease specifically and could improve the disease. We started to look for side effects. And so hyperglycemia or blood sugar abnormalities had been shown in this disease before, it turned out to be relatively mild. As long as patients were well controlled, the blood sugar abnormalities could be well controlled with diet or modification in their medication. So this is an example of what happens in the placebo arm. So this is just a patient who did not receive the drug, and as you can see, did not really develop any benefit because the disease looks pretty much the same after week 24. But this is a patient who did receive the drug. And this is something that just has never been really seen with medication before. You could get this type of result maybe with surgery, but never with medication, where there's just such a dramatic improvement of the eye disease after 8 infusions of this medication. This particular patient, I think, when his proptosis reduced about 6 millimeters, which would be very hard to achieve even with surgery. So it appears that teprotumumab is a reasonably effective drug, and almost 80% of patients had a response to this drug. And the improvement was about 2.5, and in the phase 3, even more, closer to 3 millimeters reduction. And the worse patients were, the more the effect was due to this drug. And so just to complete the overview of what we can do, there's also hope for surgery. And I've been advancing doing single-stage surgery for orbital decompression. So even if the drug works really well, it may or may not work completely, or some patients still may opt for surgery. And this is what's been done in the past once we reach the stable phase. And I'm a big proponent now, as I've progressed in this process, to do both sides at the same time and to try to do as much surgery as possible just in a single stage without multiple stages of surgery, and to really address how patients feel and look, because it really is important for the social situations, just not to look like a movie star, not to look like, have cosmetic surgery, but just to return to what they looked like at least as much as possible in the past. And we have a little motto of "Be You Again," and that really is what patients are trying to achieve. It's just trying to get back to their normal look and function that they had before this disease, hopefully in a single-stage reconstruction. And I'm just going to show some examples because I think it's important for a lot of people just to know that there can be a light at the end of the tunnel, whether the medication is right for you or whether the surgery is right. It really has to be a customized approach, talking to someone who really knows a lot about this disease. And in this particular circumstance, we're talking about aesthetic functional reconstruction. And that means that form follows function. And what we want to do is we want to return to the pre-disease or even improve upon that appearance. And this is just a case where they did a decompression on a patient to really dramatically return to that appearance. And you're going to hear much more about this process from Christine. So there are many key factors when you talk to a surgeon. A is they really need to do many of these surgeries per year to really understand the nuances. I do a couple hundred per year, and I think it's really important to think about the key factors in customizing this approach. And first of all, that's a patient's goals. I can do surgery in many different ways and for many different patients, but it really comes down to what their goals are, what the risks, what they want to achieve. And what I can achieve is often dependent upon the type of disease they have that kind of formulates the risk profile, whether it's more of the fat predominant or muscle predominant, obviously how severe, and whether there's any double vision, what their bone structure is like, and then what we can do for other aspects of the face. And I'll just briefly show a few examples of how we can walk through that for many patients. This is an example of Christine, and this is a picture, a selfie I think that she took of herself while this disease was probably in its full force, and then after surgery that we did quite a while back, as she said, in 2013. just another example of a patient where we can do bilateral surgery and eventually improve the double vision and dramatically improve the comfort that's associated with this disease. And it's important to create a natural lower eyelid appearance in addition to an upper eyelid appearance. And we're able to do that now with just modifying the surgery. Did a lot of research looking at eyelid contours and thinking how we can improve the normal eyelid contour after decompression, and then kind of translated this into the surgery techniques, which are some nuances as far as where we do the surgery, how we do the surgery, just to achieve some results where there's no longer white under the eyes, between the eyelid and the colored part of the eye, so that that can be dramatically improved with just one surgery, not multiple reconstructive surgeries. These are just some examples where you can see that. The other aspect is looking at the cheek junction, because a lot of patients have an expansion of their cheek junction or have new eyelid bags. That's one of the first things they can sometimes notice, and we can often address that. So instead of just saying, oh, well, we'll do the decompression and then maybe do a blepharoplasty or nothing later, we can do that all at the same time. A little cheek lift, remove the eyelid bags, and kind of get rid of that lower eyelid appearance that is just that they just don't like, in addition to working with the upper eyelids. And you can see a nice example here. And this is, again, just an example using decompression surgery. No eyelid surgery yet. If we want more, we can always do that. But these types of techniques can often be very helpful at improving the lower eyelid and making a nice junction. And then finally, just an example where we can do the upper eyelids, lower eyelids, and even work on a little bit on the lower face, because this disease often changes the shape of patient's face. And I get this all the time as to why my lower face is so full. And it often is an expansion of the lower fat due to the disease, sometimes due to steroids, but often due to the disease. And I can modify the buccal fat or make the lower face a little thinner and dramatically improve that also. So just as a summary, we have a whole service that's devoted to the thyroid eye disease and, for taking care of patients, where we look at research, clinical care, and working on a financial program for philanthropy too, to help patients even afford this surgery or any copays or even transportation to their appointment. So we really want to, as I said, take a holistic approach to this process and to this problem. And without further ado, I will begin to turn to questions soon, but I'm going to introduce Christina, who can really tell you about her thyroid journey. And Christina is really an inspiration, and so nice of her to participate and to really make herself available for this. But, I think it's important to really not only see the light at the end of the tunnel with before and after photographs, but really to hear from someone who's been through things and really to inspire others that, there is hope and you can take small steps in many different ways to begin to achieve that. Christina, thank you so much for joining us today.
Thank you. It's my pleasure. I love helping out for this kind of stuff. So just to start and recap again, I was diagnosed with Graves' disease in 2006 and thyroid eye disease in 2011 after getting a treatment of radioactive iodine for my Graves' disease. A few months after the treatment, I noticed my eyes looked like they were bulging. They were very wide-eyed, dry, and sore. So I went to my endocrinologist, and she told me that I now had thyroid eye disease and that there was no cure, and referred me to an ophthalmologist. After that, I spent 2 years going to different doctors, endocrinologists, ophthalmologists, oculoplastic surgeons, holistic doctors, trying to get different opinions and different treatment plans because I wasn't liking what everyone was telling me. I was being told to not do surgery because it was too risky, that I could go blind, it wasn't worth it. I was told to get used to it. This is what I was going to be looking like. This was my new normal. I was told by some surgeons that they could do a surgery, but the problem wouldn't be completely fixed and I would still have bulging eyes. So it was very, very discerning, and it was really hard to continually going to doctors over and over and over and basically just being told, get used to it, this is what you're going to look like. And not only just the way I looked, it was painful. The dry eyes, there was days where my contacts would just fall out of my eyes. They were so dry and just uncomfortable every single day. I tried to help my eyes look and feel normal again by taking steroids. I used topical creams, gel eye drops, cold compresses. I went on special diets. I took special supplements. I was trying everything possible to, make my eyes look a little bit better. Then in 2013, the dryness was getting really bad. The eye pain was daily, and I had double vision when I would look up. I was ready to settle with a surgeon who said he can get my eyes set back about halfway, and that was the best news I have heard for 2 years. And I was ready to book the surgery when one day I came across a video that someone had posted in a Facebook Graves' disease support group. The person had commented about the surgeon in the video and his amazing work with the thyroid eye disease. So I watched the video and I could not believe what I had just seen. It was the first time in 2 years where I felt hope. I saw unbelievable before and after photos of patients and finally felt that maybe I could actually look normal again. The next day I called and booked an appointment to see Dr. Douglas at the Kellogg Eye Center in Ann Arbor, Michigan. That was a 4-hour drive from my home near Chicago, but I knew I just had to see this doctor and just get one last opinion before I booked the surgery. A few weeks later, I traveled to Michigan to meet with Dr. Douglas. My mom came with me for extra support. Dr. Douglas looked at my eyes. He listened to my 2-year battle of seeing different doctors. He took some measurements and then started explaining the different options and surgical procedures. We asked how far back he thought he'd be able to get my eyes back, and he said, all the way, you'll look like your old self again. My mom and I started to cry, and at that moment I knew that this was a guy. I finally found someone who really was educated about this disease and about the surgery. I was 110% confident and trusted Dr. Douglas that this was the way to do it. 2 months later, I returned to Michigan for my orbital decompression surgery in my right eye, and then a week after that, we did surgery in my left eye. The recovery wasn't bad at all, especially the second go-around, since the nerves of having surgery were gone. I was really excited to go back the following week for the left eye surgery because I had already noticed such a huge change in my right eye. After the surgery, I slept in a recliner to keep my head elevated. I used lots of ice packs, the pain medication that was prescribed to me, and on the second day after the surgery, I basically felt completely fine. I just looked awful with 2 black and blue eyes. You look worse than you actually feel. When my family and friends saw me, they could not believe the dramatic difference in my eyes, even with the swelling and the bruising. You could see that they had set back so much, and I was starting to look like my old self. After about a month, all the bruising was gone, and I was back to my old self again. I felt great. No one knew even I had surgery. You couldn't see any scars. To this day, people still have no clue that I had major eye surgery. And I show them the pictures, and they just can't believe that's what I used to look like. The surgery changed my life. It was becoming extremely difficult to go out in public. I was very self-conscious. I didn't want to leave my house. Started feeling depressed. After the surgery, I didn't feel embarrassed to leave my house anymore. I felt pretty, and I was so incredibly happy again. It's been 6 years now since the surgery, and I would do it all over again in a heartbeat. It's the best decision I've ever made. It's difficult to look back and see these old photos of myself and remembering how bad my eyes actually were. I don't know where I'd be if I hadn't met Dr. Douglas. He has a great gift, and he changes people's lives with it, and I'm honored to be one of his patients.
Well, thank you so much, Christina. And I certainly I feel embarrassed, but thank you so much for all the kind words. But I think what's really awesome is that you have such a great spirit and attitude and wanting to know more. And if there's one thing that I could encourage people to do, and that is to ask questions and to not kind of feel satisfied if it's not, it's something you just don't feel comfortable with, and to ask more questions and to, to keep, moving along and looking for, even better answers and not to give up because, so many people, can have recurrences or other things and it can be lots of bumps in the road, but it often is, moving forward and dealing with that. Christina, just, without, really talking about the surgery, how did you, deal day to day with the eye disease and the impact upon your social life and what you were doing? Because I think a lot of people can relate to that and hopefully find some inspiration.
Yeah, it was really hard. I mean, I was single and trying to date and stuff, and I would try hiding the way that my eyes looked with makeup, or I would try to squint my eyes, trying to make them look smaller, because it was really hard to be out in public, especially if people didn't know why your eyes look like that. I'd get people coming up to me and saying, like, well, why are you staring at me like that? I, I can't. I can't make my eyes smaller. It was hard. My sister got married during that time, and I hate looking back at her wedding photos because of the way that my eyes looked. Um, and then just on a comfort level, I slept with eye masks. I put gel eye drops in my eyes constantly, wedding drops throughout the day. As I said before, like there's days where my contacts would just fall out. Um, I tried, putting ice packs on my eyes to help with the pain and the puffiness. It was very difficult. So you have like your little routine that you do every day, just trying to be as comfortable as possible. Um, Even I got a different pair of glasses that kind of hid my eyes a little bit. And wearing sunglasses all the time because your eyes are very sensitive to light. It wouldn't even be that sunny outside, and I would still be wearing my sunglasses, one to kind of hide my eyes, but also just because they were so sensitive to the light.
And I
At
think
work, luckily, I only worked with a couple people, but that was pretty much the only time I would go out is just to go to work because I really didn't want to go out in public. It was it was a very hard time.
and I think that's you pointed out many things, but a couple of things certainly with the pain. And I've heard a lot of people say, "Well, my doctor told me if it's painful, it can't be thyroid eye disease." But I really, I wince when I hear that because you had mentioned the pain of dryness, dry eye, your contact lenses falling out. I think that creates a pretty good visual picture. Did you also have some pain pressure behind your eyes that
Yes.
was kind of a difference than the dry eye? And maybe you
Yeah,
can
it,
kind of
it
just
was definitely a pressure. It literally felt like someone was pushing your eyeballs out of your head. Um, so you got the dryness pain, and then you also have the pressure pain. Um, and it's almost like you would get used to the pain because you dealt with it daily. And it never really got better. Even when you went to bed, it didn't really go away. And because I couldn't close my eyes all the way when I would sleep, that's why I would sleep with an eye mask just to help with the comfort and also to just to keep the light out. But yeah, it was pressure definitely. So
yeah. And those are good tips.
firsthand experience, it's definitely pressure pain.
Yeah, those are good tips. I mean, I often will have patients sleep with a mask or saran wrap underneath the mask so that their eyes are protected at night because they can't often close them. You can use a little bit of ointment inside the saran wrap. For the pain pressure, that really, I've had patients who have even been on opioids and had real problem with the pain pressure. And we just did a study where a little bit of Botox to the temple can help temporarily, but often the decompression helps a lot because it decompresses the nerve that often can cause this pain pressure. But that pain is often so underreported. And there are some things you can do, but often typical pain medication doesn't work all that well for that. But certainly the Botox and sometimes even decompressing it with a modification of the surgery can help. Uh, Dr. Larian, I was hoping to have you talk maybe a little bit more about some of the testing. So a lot of patients will come to me with the typical scenario that They've been started and been diagnosed with Graves' disease. They have been started on methimazole, but they're wondering whether they should continue to check their immunoglobulin levels, and also how they can adjust their hormone levels to feel just more vigorous, because they just don't quite feel the same.
Great. Those are very good questions. It's fairly easy to assess the hormone levels and how they're working. If you do blood tests, you can check and see what's your thyroid hormone production. During the course of treatment with methimazole, you also, on a regular basis, check the antibody level to see how your immune system is responding to the treatment that you have. Because at the end of the 12 to 18-month period where you do a trial of medication, you again check the antibody level. And if the antibody level is significantly diminished and very low, you can be fairly certain that this patient has gone into remission, and they can probably stop treatment and be followed thereafter. The regularity with which you check the blood test differs for patients, because it all really has to do how well they're doing and how well they're responding. So if the patient are doing well, they're not symptomatic, they're not having rapid heartbeat, they're not feeling spent and tired and weak and losing weight, then you know that the treatment is effective and they're doing well. And so the number of times you do the blood test is less frequent. And obviously, if they're having more issues and symptoms, then you do the blood test more frequently to try to adjust the medication doses so that you can compensate. Because sometimes what may happen is that they may be over-medicated and not produce enough hormone. They may be under-medicated and producing too much. So it's a fine balance, and it involves you having close communication with the patient and talking to them and seeing how they feel. Because it's not only the lab test that's meaningful, it's also how they feel that's meaningful. And then you combine the two with each other to come up with adjustments in the regimens. But the key is ultimately what the numbers are at the end of the 12 to 18 months, because that's an indicator for you if you need to continue to treat medically, or if they're in remission, or that medications are not necessarily working, and then you may need to move up to the more intrusive treatment, iodine or surgery.
Great. Thank you. And I often will recommend a low inflammatory diet for patients, and I've seen not that it can cure Graves' disease, but certainly can sometimes help with those fluctuations, eliminating dairy, some of the red meat, some of the pro-inflammatory food, and we'll have a whole webinar about that. One of the questions we received is how protruding guys need to be for decompression. And I'll answer that in that I showed some very significant examples, in the before and after. But I've operated on patients who just wanted a very small improvement, or had one eye that was a little more bulgy than the other, or just wanted to, to give largely an improvement in their appearance. But that Graves' disease had really contributed to an appearance that they were unhappy with. And that can be even just a couple millimeters of a decompression. So I think if your surgeon is very, very comfortable in doing these types of surgeries, you can do them extraordinarily safely, probably safer than or as safe as a blepharoplasty. But, I think it really comes down to talking to the patient about what their goals are, and then what the risks are, and having a very frank discussion. Is like, this is what we can do, here's what the risks are. And you can do this without skin incisions, you can do it with just fat removal, bone removal, and there's various ways and various risks associated. And one is not perfect for any individual patient. I mean, I'll often have patients say, well, my surgeon recommended that fat was so much less dangerous than bone. in some patients that's true, and in some patients it's not. It really kind of just depends on the composition of the fat or the bone, and you just kind of have to have that discussion as far as what your goals are, and then what are the potential risks. One other question that arose was, is there a chance of having a recurrence after orbital decompression? Well, as I said, normally Graves' disease and thyroid eye disease reach a remission or a stable phase where there is no progression. However, in about 4% of cases, whether you have an orbital decompression or not, you can have a recurrence. Now, this is much higher in smokers than non-smokers, and that's one of the biggest factors in making this disease more severe and long-lasting is smoking. But in non-smokers, a recurrence is unusual, less than 4%, but also it's usually well treated. And that's whether you've had a decompression or not. And I tend to operate on patients earlier and earlier, just as they come out of the active phase, because any kind of recurrence is actually very well treated. And I really don't see the reason to make patients wait many years with this disease when it really has shown no benefit. Operating as soon as the disease has become stable, because we can control those reactivations and recurrences very relatively easily. Well, I know that we are beginning to approach the end of our time here, and I'd like to ask Christina and Dr. Larian to maybe summarize any major point that they would like to leave everyone with. I know they've made a major contribution to this webinar today, and I'd just like them to kind of give any kind of summary or glean the one thing that they'd love people to know moving forward based upon this webinar today. Christina, maybe I'll let you start, and then I'll let Dr. Larian go.
Sure. My biggest thing is, we just said it, but don't give up hope, and don't be afraid to ask questions. And don't be afraid to ask for before and after pictures. There's a lot of doctors that I talked to that wouldn't show me pictures. Or when I did see a picture, I honestly couldn't tell if it was before or the after. And you want to know that they're experienced in doing these. It's not that common of a disease, so you want to make sure that they really know what they're doing, and that they perform this surgery often, not just once every few months or so, and that they have a lot of experience in it. And it's okay to get a second opinion, a third opinion, a fourth opinion, and wait until you find a doctor that you're very comfortable with. And there is hope, and just don't give up.
Awesome. And Dr. Larian, I'll let you kind of leave us with a wonderful point that I know that you're so good at dealing with patients and bringing things across. So I'll let you summarize a take-home point or two.
I'd like to first echo what Christina just said. Please don't operate out of fear. There are very good people out there treating this condition. And I think that your first job, first and foremost, is to find the appropriate physician for yourself. The appropriate endocrinologists, surgeons, orbital surgeons to accomplish this task and answer your questions and get you out of the fear state, because this disease can be treated very well, and you just need the right team to allow that to happen for you. And just like I tell all my patients, I may be the appropriate surgeon for some people and not for the other, and that doesn't say anything per se about me, but rather how it works. Because treating diseases like this requires a team approach, a partnership between the physicians and the patients. And so finding people that you have faith and trust in is important, that you can pick up the phone and ask questions. Asking questions, just like Christina said, is really, really important. Getting all your questions answered is so important, because once you have faith and trust, that's half the battle, I'd say. And the art of medicine comes in instilling trust and faith in your patient, and by empowering them with information and giving them a solid state to stand on in making those decisions, just like Christina experienced when she went and met Dr. Douglas. That's really important. Once you feel like you have the right person on your side, you will do significant things. significantly better. And that will come when you ask questions and your questions are answered appropriately. And when your instinct it tells you that this is not the right situation for you, trust your instinct and seek other physicians until you find the correct thing.
Great, and thank you so much. And there, frankly, just to add to that, there are some questions where we just don't know the answer, and I think having someone who's willing to say, we just don't know that answer is the most accurate and the most honest. Well, there are other questions that are rolling in, and I'll assure people that if they ask questions, we'll assign them appropriately and answer them, and get so that each of the questions will be answered on the chat. In addition, the webinar will be posted on my website, RaymondDouglasMD.com, and probably also on Dr. Larry, and there will be a link there to his website and for more information, and you can ask questions, in those venues also, because I think it's the most important to really understand your own circumstance, and it's often hard to answer questions thoughtfully in a brief period of time, but we really want to do so in a very thoughtful manner. I want to thank first Global Genes for helping us put this together. They're experts in rare diseases and really helping to bring information to patients and other physicians, frankly. And I'd also like to thank Dr. Larian and Christina for participating. It's really always my pleasure to deal with Dr. Larian. We share many patients. And Christina, it's just always wonderful just to hear from you and to see how well you're doing. Even though I don't get back to Ann Arbor anymore, being in Los Angeles now, Chicago's still a nice place to visit, though, too. But thank you all so much, and we certainly will try to answer all the questions that come through on the chat. But thank you all for participating. And I'll turn it over maybe to Global Genes to end and to give any kind of summary information that might be needed.